All right, let's talk about one of the toughest, most high-stakes areas you're going to face on the NCLEX, pediatric emergencies. We're going to cut right through all the noise and focus on what really truly matters, not just for your exam score, but for keeping these little patients safe. And this right here, this is the whole game. You have to get this in your head. The NCLEX isn't trying to see if you can recite a textbook. It's testing if you can recognize a crisis as it's happening and make a smart clinical judgment. And I mean fast. And believe me, the stakes are as high as they get. When we're talking about kids, the tiniest, most subtle signs can mean a patient is about to crash. Spotting those signs isn't just some academic exercise. It's a life or death nursing skill, and you can bet the exam is designed to find out if you have it. So here's the bottom line. It's great that you know the name of a disease. That's step one. But the points that get you to pass come from knowing what you're going to do about it. Who do you need to see first? What's the number one thing to monitor? What is your absolute priority action? That's what matters.
And that's exactly what we're going to do right now. Think of this as a sneak peek into the exam coach's method, a really powerful way to get your thoughts organized around these super complex pediatric cases so you're not caught off guard.
So why do so many really smart, dedicated nursing students get tripped up by these pediatric questions? Well, it almost always comes down to falling into a really common trap. Take a look at this list. Does any of this hit home? Maybe you've gotten a question and you couldn't figure out if you should be thinking long-term management or, oh my gosh, emergency. Or maybe you've just frozen up when a question asks for the very first thing you should do for a kid in respiratory distress. See, it's not that you don't know the facts, it's that you don't have a system to apply them when you're under pressure. And that's the million-dollar question, isn't it? How do you actually build that bridge from just knowing symptoms in your head to making confident, safe decisions in the moment? Well, it all starts with having a solid structure. So let's put this into action with our first framework. We're going to start with pediatric GI, and we're going to split it into two very different ways of thinking: chronic monitoring versus acute intervention. Now look at this. This is how you start to organize your brain for the NCLEX. On the one side, you've got your chronic issues, right? Things like celiac and Hirschsprungs. Your job there is all about the long game: nutrition, family teaching, watching for complications over time. But then on the other side, bam, you've got an acute emergency like Intussusception. Your whole world shrinks. Your focus becomes laser sharp. Assess fast, prioritize, and get this kid ready for surgery. Two totally different mindsets. So, just to set the stage, think about our two chronic examples. Celiac disease is an intolerance or reaction to gluten. But Hirschsprung's, that's a plumbing problem. It's a mechanical obstruction because the nerve cells in the rectum are missing from birth. Both require your full attention as a nurse, but from very different reasons. Okay, let's apply this. So you're looking at a newborn, and you see these classic signs of Hirschsprung's. Using this framework, your brain immediately screams mechanical obstruction, blockage. So what's your priority? Is it feeding? No way, there's a blockage. Is it just teaching the family? Not yet. Your first priority is assessing for the deadliest complication, which is a bowel infection called enterocolitis. The framework forces you to see the immediate danger. Okay, now let's flip over to that acute emergency side, intussusception. And I'm telling you, the NCLEX absolutely loves this classic sign right here: the red, jelly-like stools. That's not just some catchy phrase. That is blood and mucus mixed together because one part of the bowel has telescoped into another and is literally dying. This is your screaming red flag that you have a surgical emergency on your hands. So you get a question with this exact presentation. What's your priority? Are you thinking about pain meds or maybe offering the baby a bottle to soothe them? No, absolutely not. Your framework tells you this is a surgical emergency. Your priorities are to make that child NPO, get an IV started, and notify the provider immediately. See the shift in thinking? It's everything. All right, now let's take that exact same logic and apply it to an area where the stakes get even higher: pediatric airway emergencies. Because here, being able to tell the difference between two things that look similar can literally be the difference between life and death. This slide is absolutely critical. On the left, you've got epiglottitis. This is a 5-alarm fire medical emergency. That child is sitting bolt upright, leaning forward in that tripod position, fighting for every single breath. They're drooling because swallowing is so painful, their airway is swelling shut. On the right, you have Croup, It sounds scary with that seal-like bark, but the fever is lower, the distress is different. You have to be able to spot the differences in a split second.
Now, no matter which one it is, your priorities follow this general path. But I need you to look at number 4. This is non-negotiable. If you even suspect epiglottitis, the one thing you must never, ever do is try to look in their throat with a tongue depressor. Ever. That one move can cause a spasm that completely closes their airway. It is one of the biggest, most classic safety traps on the entire NCLEX.
So here it is, the final scenario. You walk in and you see a child with all the textbook signs of epiglottitis. What is your very first move? Are you going to grab a set of vitals? Call the parents? No. Your framework tells you, protect the airway. You make sure nothing agitates that child, you get them in a position of comfort, and you prepare for an emergency intubation. Nothing else matters more. And really, it all boils down to this, doesn't it? This simple, powerful sequence. You have to recognize what's in front of you, you have to prioritize the single biggest threat, and then you have to act. And that's the beautiful thing. That's the thread that ties all of this together. It doesn't matter if it's a confusing GI case or a terrifying airway crisis. The fundamental principles of good nursing judgment, of safe nursing judgment, are exactly the same. That is what the NCLEX is testing you on.
And look, this is why the exam coach's approach is such a game changer. We don't just throw a list of pediatric conditions at you.
We train you to spot the complications, those subtle signs that tell you your patient is in trouble. We train you to know exactly what to do first, what matters most when every second counts. When you put it all together, what we're really doing is training you to have NCLEX-level clinical judgment, the kind of judgment the test demands, and frankly, the kind your future patients deserve. So never forget this. On the NCLEX, the safest action and the most timely action will always be the highest scoring answer. This was just a preview of how to think. The real question is, are you ready to master this framework for every single scenario the exam throws at you?